However, Dr. Ragheb deserves a wonderful introduction. You know, it's our true pleasure to have him with us this morning. Quickly beginning his training, for those of you who don't know him, at University of Michigan, continuing on to residency at University of Maryland, and then following up with fellowship at NYU. Dr. Ragheb is now the director of the Division of Neurosurgery, as well as the chief of surgery at Nicklaus Children's Hospital in Miami, as well as the immediate past president of the ASPN in the realm of pediatric neurosurgery, and has served on the executive committee for 16 years. Dr. Ragheb's accolades and positions of leadership extend far beyond these few mentioned and more that we have time for, but he has contributed monumentally to many facets of pediatric neurosurgical advancement within epilepsy, neurotrauma, neuroendoscopy, and neurooncology. However, his impact on the advancement of global neurosurgery will be the focus of his talk this morning. Dr. Ragheb is an unparalleled mentor to so many of us in the field, whether lucky enough to work with him directly or through the observation of his consistent example of humility, kindness, selflessness, and tireless and continual service and contribution. So Dr. Ragheb, I turn it over to you, and we look forward to your comments this morning.
Well, thanks so much for the really kind introduction, and you and Rupa for the invitation. Can you guys hear me okay? And the slides
that sounds great.
Yeah, right. So thanks to all my friends in Cornell for the opportunity here. It's really an honor to be with you today and to give grand rounds, and particularly when it starts at a civilized hour, unlike most other programs. By way of financial disclosures, the only thing really to say is that, there was a small grant given to our program to fund the initial fellowship in 2015 by Medtronic. Everything else out of the family checkbook or out of donations, and from the foundation that we started in 2009, Haiti Healthy Kids. So I also want to acknowledge the fact that, this is it's a little embarrassing for me to be talking to the folks at Cornell about global surgery. You guys are obviously a leader in global surgery. I think your work in Tanzania speaks for itself, as well as the two spectacular conferences that I've had an opportunity to participate in with you over the last few years. And I really look forward to the work product out of the 2021 Education Symposium. I know that Caitlin and Gail Russo are working diligently on that. So again, it's really my privilege to be with you today, particularly since I'm talking to the well-informed. I also don't have to point out the fact that this isn't a one-person operation, right? Nobody does this kind of thing alone. And although somebody's always at the point, this is really a collaborative effort. And if it weren't for the support of my children's hospital and the Jackson Health System, and then the folks at the University of Miami, and et cetera, this wouldn't have happened. So I think that's sort of obvious. I think the folks that are have been most helpful to me in starting this by providing infrastructure is Project MediShare. And for those of you who don't know Project MediShare, this was a grassroots effort from the University of Miami, started in 1994 by Drs. Barth Green and Arthur Fournier. That's Art, and there's Barth. Although Barth was the chair of neurosurgery for nearly 30 years, he would go to Haiti and he never practiced neurosurgery. He did primary care in the plateau, treating diabetes and hypertension. So the focus of this was to share medical resources with those in the least served area, which is the border between Haiti and the Dominican Republic, which is called the Plateau region. Although it's maybe 50 miles from Port-au-Prince, was a 5-hour car drive back in those days. And the goal here, of course, was primary care. They were very successful over the years. The program still exists. And in their annual report this year, it shows their productivity and focusing on 5 primary areas of effort, right? Which is maternal health, recognizing that if you want healthy babies, you have to start with healthy moms, community health, and then health and nutrition, vaccination and nutrition for children, building capacity by helping build resources for the Haitian medical system. And then by default, MediShare has done emergency response, and we'll talk a bit about that later in the talk. One of the things that MediShare was very successful at was creating an educational system. And I think the shining example of that was their family medicine program. They realized in the plateau there were not enough primary care providers to take care of the people. So, well, what do? You create a family medicine training program. That makes perfect sense if you're a family medicine physician. So they went out and used education as a method to address the healthcare deficiencies. And because there was no primary care and no primary care program, they went to Cap Haitian, which is here closer to the plateau, which is in this region, and created clinics along the border between the Dominican Republic and Haiti. And those series of clinics supported the family medicine residents. The first group of graduates became the faculty. The faculty at the University of Miami mentored them. It was a model that I admired and I thought was remarkably effective. But of course, when you create a primary care clinic, all of these children show up. And one of the things that was very evident to Dr. Green and the others from family medicine is that the children with neurological or neurosurgical disorders could not get access to care, and there was nothing that their primary care system could do to help that. And after being badgered for a couple of years by Dr. Green to come take care of all these neglected children, I finally relented and said, okay, well, I'm going to come to Haiti and take a look, but I'm not really sure you could do pediatric neurosurgery in Haiti. And, you know, my impression of Haiti was much like everybody else's, right? Minimal infrastructure, basic medical care was absent. So why do you think you could do something as sophisticated as pediatric neurosurgery safely, particularly when the biggest consequences of what we do are wound breakdown or infection if things go badly? And who's going to provide that kind of care? So I went in 2002 to find out what the lay of the land was and to meet with the neurosurgeons, because if you're going to do this, you need somebody to partner with, right? I think we all understand the importance of not only careful patient assessment, and surgical care in the operating room, but that implies that you have to provide careful care afterwards. And who was going to take care of these children after I left? So I met with the neurosurgeons within the community at the time, and there were 3 junior neurosurgeons, and then a single senior neurosurgeon who was busy clinically. There were a couple other senior surgeons who had trained in France but no longer operated. And the only one who was still operating was Ariel Henry. He's images on the lower right. The junior surgeons were gentlemen who had rotated with Dr. Henry during their general surgery training, had gone to spend a few weeks or months in Martinique because of the comparable French system of healthcare. And then they were true general surgeons. Their business card would say Dr. X, urology, gynecology, orthopedics, neurosurgery, plastic surgery, et cetera, et cetera. And they did it all. And I made an effort to work with these gentlemen and include them in the program, recognizing that if we were going to do this, I had to have someone to take care of the patients afterwards. And the key was going to be to find somebody capable that could manage the children and whom I could teach. So I also held a clinic in advance to understand what sort of pathology were we going to see. And the obvious thing is untreated hydrocephalus. And for those of you who have never seen untreated hydrocephalus, you know, most of us know that in infants, children don't die from hydrocephalus acutely, right? The head just keeps getting bigger and bigger and bigger. And that's what you see in neglected and untreated hydrocephalus. And there was a tremendous amount of that when we arrived in Haiti in the early 2000s. So like many well-meaning folks who see a problem and try to help, we returned in 2003, a few months after the initial visits. And I was fortunate at that time to meet Paul Farmer and be convinced by Paul that with careful planning and forethought, you can do complex surgery and provide safe medical care if you attend to the details. And we were fortunate to be invited to work in Conj at the hospital that Partners in Health and Dr. Farmer started. We used their operating rooms and their wards because they had a remarkably low hospital-acquired infection rate and capable operating rooms. I had communicated with Paul several times via email and talked on the phone. I never met him, and we started in the hospital, and he was not there. And he'd like to tell people that I'm the only person that threw him out of his own operating room for talking, because I was trying to coach my fellow, and he was talking too much, and I didn't know who he was. We sadly lost Paul recently, and he's you know, we all miss his leadership, his friendship, and you know, global health will march on better because of Paul. So in 2003, we went to work in Conj. We took a team of folks. We brought all our own equipment. Everything was salvaged and left over. Even my neighbor came to help mop the floors and turn over rooms. And we were able to help about 15 children. We brought one of the local Haitian general surgeons with us, a gentleman named Patrick Valzant, who promised to take care of the children afterwards. We left all of the equipment in his hands, as well as the necessary antibiotics should there be an infection. He provided follow-up care as best he could. Our program continued to return with pre-op visits, operative care, post-operative visits, and then subsequent visits to follow up on the children over the years. And as is true for any Ponzi scheme, if you can get your friends involved and convince them that it's a positive thing, you can sell more of it. So I was fortunate to have many of my friends from across the country and colleagues come join us in the effort. And what started off as just a University of Miami thing where we would go a couple times a year grew to programs from across North America with teams going almost once a month. And the team that would be there next month would see my post-ops and I would see theirs. We would see pre-ops and set them up for the next team. And we focused not only on taking care of the children, but also on finding a capable in-country partner. And what I realized is that those folks who had started their training in that austere medical environment and were taught by people who with limited ability were taught surgical techniques that were very difficult to change. It was a real challenge to get the people who were doing neurosurgery to understand where the opportunities for improvement were. And that was a lesson well learned, which was reinforced to me by Ben Worf. And I'll add a few more sentences about that in a moment. But it's really difficult to change practice patterns once they're well ingrained. So although we spent most of our time trying outside the operating room, trying to teach not only doctors, but nurses and the other allied health professionals associated with neurosurgical care, we really did not make a lot of traction. After working with one of the surgeons who was doing neurosurgery in Haiti, we moved to the gentleman who was considered the most senior. He's in the middle. His name's Bernard Priere. He's the chief of neurosurgery at the General Hospital. And again, the issues revolved around his limited access to tools and the techniques that he developed in order to compensate for that. Our challenges in changing the way they practice neurosurgery that was contemporary and applicable to children. We were able to hire a full-time Haitian American nurse who still works with us 20 years later. But the focus went from just providing care to trying to find a partnership with someone that we could use on the ground in Haiti to be the leader of an educational program for the neurosurgeons of the future. The key also always is to work with the local surgeons to see if you can't make things better. So I think when you look at models for education, there are programs like the remarkable partnership with Tanzania that Dr. Hartle and your department has, where you find a capable department that needs mentorship and leadership. They may need equipment and supplies, but they do good basic neurosurgery, and they are a foundation on which to build. Unfortunately, we didn't have that in Haiti because there was no basic neurosurgical training, and there's extremely limited ability. So although the twinning model, like you have at Cornell or at Emory, is very effective when you have a partner that has some level of ability, it doesn't work where there is no neurosurgical education system to begin with. The alternative would be what I call the Ugandan model, for lack of a better term, which is where you go into a community, you assess the situation, recognize that you can't work with those providing care there, and start de novo by creating your own hospital and infrastructure, and then hiring your own trainees and building from the ground up. And that requires a tremendous amount of resource and a life-changing commitment, like Ben Worf did by spending 10 years in Uganda, moving his family there. That's I admire that, but in spite of the fact that we all have busy lives, I think my wife would have killed me if I told her I was going to go to Haiti for 10 years. So it obviously doesn't work for everybody, but it is an effective model if you have that level of commitment, both personally and financially. And then there's this last one, which is what I call the public and private or philanthropic partnership, which is where you bring resources from outside the country and partner with the government in an effort to try to use their educational and administrative infrastructure to build a program. And I went to talk to Ben about this after one of his spectacular lectures, and the advice I got was, don't bother dealing with the corrupt local government. It'll never work. I'm still not sure it's going to work, but I tried, right? So I met with every minister of health for about a 10-year period, and here are several of them, and they had very little traction. It was just starting to get at the attention of their leadership after the Aristide administration, and that was mostly through the intercession of Dr. Green and Henri Ford, who's now the dean at the University of Miami. He's a Haitian-American pediatric surgeon who at the time was at USC, but made regular trips to work in Port-au-Prince teaching pediatric surgery. Finally convinced them that that was a good idea. And then of course, everything came unglued in 2010 in the earthquake that devastated Haiti, and nearly 250,000 people were killed, and hundreds of thousands injured, and millions displaced. Among the many things that were destroyed, lives, infrastructure, the government was destroyed as well in ways that are hard to imagine. So the Ministry of Health, which is the upper right, and the leadership of the presidency in the lower left crumbled along with most of the country's infrastructure. And although it pales by comparison to the human loss, all of the years of supplies and equipment that we had placed in a warehouse that we purchased was all destroyed when the warehouse collapsed, and all of the equipment was lost. So we also realized that investments of those sorts didn't make a lot of sense when the infrastructure was hard to rely on, and life was capricious and unpredictable. Everybody knows the story of the world's response to the 2010 earthquake. Like the phoenix rising from the ashes, all of the resources that poured into Haiti from around the world and allowed for the construction of this tent hospital right on the airport grounds that was staffed by hundreds and thousands of volunteers from just about every institution, and then financial resources and equipment. All of that stuff ended up staying in Haiti, thankfully. The people left, and which happens after a disaster like this. But we were the benefit, and our program was the benefit of a great deal of those resources. That generator you see in the lower left is still there on the hospital campus, and it's used today to run the CT scanner. And I'll talk more about how unreliable that is, but we benefited from that. All of these resources were transferred essentially to one hospital called Bernard Mebs. And since about 2011, we've continued to work regularly in that single hospital and use that infrastructure and support to grow the facilities. Bernard Mebs, which is the gate there, is on the edge of City of Soleil, which is one of the poorest part of Port-au-Prince. Thankfully, it's only about a 10-minute ride from the airport, so it's very easy for us to get there. I can leave Miami on an 8 o'clock flight and be holding clinic by 10:30 or 11 in Port-au-Prince at the hospital. So that's allowed us to be able to go back and forth with regularity and not only provide mentorship, but follow up when needed and urgent care as needed. So those routine trips started again after the dust settled from the earthquake. Those resources were poured into one particular hospital, not only physical infrastructure, but people. And we were able to get other interested folks to provide general pediatric care and surgical care for the children. And as I mentioned, in 2015, we got a grant from Medtronic to fund a training program. Something we were never able to do was to have enough money to say to the Ministry of Health, we'll pay for the trainee for the 4 years of their education. Here's the dollars to prove it. And we're going to put it in an account set aside for them. So that was possible through this grant from Medtronic. And at that point, with the various teams that were coming on a regular basis, we were doing between 250 and 300 operations a year, but seeing thousands of children in the process. The program was finally approved by the hospital's Ministry of Health, and what went a long way to get their approval was the ability to show that there was an international curriculum that had been deployed in other hospitals. Examples were in Nepal and Vietnam. That curriculum was developed by the folks in Fiends and shared with us. And being able to show the Haitian Ministry of Health and the dean of their medical school that this curriculum could be deployed in the developing world and that we would support it was really instrumental in getting governmental approval for this training program. Obviously, during that time, many of the people who came and went from Haiti started little peripheral programs, which made it difficult. I did my best to try to say to them, hey, look, why don't you come work with us so that we can concentrate our efforts in a place that desperately needs us instead of starting independent projects elsewhere, blah, blah, blah. And I call that herding the cats, which is a polite way of saying that it's not easy to do. But we were able to say to the folks in Partners in Health that built a beautiful facility in Mirabelais, we're going to start a training program. You send us the neurosurgical patients, we'll send you a fully trained neurosurgeon when they're capable of working independently. And that offer still exists. It's on the table. We're just about ready to hire our second person. I'll talk more about that at the end of the talk. So as I said, after all of this work and the help of Fiends, the government proudly announced the opening of this first neurosurgical training program for Haiti in 2015. We had a few stutters and starts as we sent out a notice for the first examination for people who were interested. We got 30 applicants, and when the time came for the exam, only one guy showed up. And a word was sent out that this guy, who was the nephew of the cousin of the Minister of Health, was going to be the guy. It didn't go too well. So we had to take a step back and start over again. And then 2 years later, we were finally able to effectively recruit somebody who was a general surgeon who had rotated through this teaching hospital, had done his laparoscopic surgery there, and by default had become the guy taking care of all the neurotrauma at the general hospital. And he came from Cap-Haïtien, which is a city about 100 miles away from Port-au-Prince. He gravitated to those patients because he recognized nobody knew what to do with them. He was a very capable laparoscopic surgeon interested in the nervous system. And we offered him the opportunity to become a neurosurgeon. His name's Yudi Lafortune. Yudi's been with us now since 2017. He's been functioning independently now for almost a year and a half, and is the country's most capable and active neurosurgeon at this point, 5 years later. Now, granted, there's plenty of room to improve, and we look forward to working on Yudi's microsurgical skills. But as it stands now, Yudi's become the neurosurgeon for the country of 11 million people. Yudi's education was initially online in a curriculum that we had, again, borrowed from Fiends. We had a very capable resident, Ashish Shah, who was a whiz with all of this sort of stuff. And he was able to share with Yudi all of the University of Miami's neurosurgical educational material, as well as a digital library. We were able to create a weekly PACS review session with Yudi, where we would go over cases that had come in over the week, pick a case that he had managed, and talk about management. What started off as maybe a 3-year thing has become a 4 or 5 year mentorship, but it's focused on basic neurosurgery. And I think at this point, Yudi's become quite capable at basic neurosurgery, which includes trauma, right? The things that kill most people in the developing world, the children who are neglected. That's, of course, our thing as pediatric neurosurgeons, and spine, which is a tremendous problem not only because of trauma, but the degenerative diseases that are neglected. And Yudi's become an excellent teacher in his own right. And in this picture here is Carolina Sandoval. She's now at the University of Minnesota. She was our fellow a few years ago, and she came to work with Yudi in Port-au-Prince. And Yudi's become an excellent teacher. His ability to do ETV, CPC, and distorted anatomy far exceeds what we North American trained neurosurgeons accomplish, because that's all he ever sees, right? That's 80% of his endoscopic practice is that kind of endoscopy. But the challenges of herding the cats persist. The benefits of this kind of work goes beyond just the patients we take care of. And I know everybody's familiar with this this editorial from the New York Times a few years ago that tried to shine some light on the idea that if you develop surgical infrastructure, it isn't just for the patients that get the operation. It benefits healthcare infrastructure. And I think it's taken a long time for the world to recognize that. But thankfully, I think we're getting there. And that's manifest in many ways, one of which, of course, was this Lancet Commission's report talking about how global surgery is so far behind in serving the world's community that the opportunities are tremendous. But for us in Haiti, all of those resources that have gone into taking care of the children with neurosurgical problems and the adults that come to the hospital has resulted in this little hospital that was started off as on the edge of City of Soleil by a pediatrician who wanted to serve the community. He's the Mevs in Bernard Mevs. It now has a very reasonable pediatric ward and a pediatric intensive care unit. Its operating rooms went from being little closets to being much better than they were. There's actually reliable air conditioning, which is, if you're working in Haiti, you need air conditioning. And the CT scanner there in the trailer that was donated shortly after the earthquake and is now limping along was the first one outside of a private facility anywhere in the country when we brought the unit into the city. So that infrastructure has helped tremendously improve healthcare across the country. And it's also changed how we practice here in the United States. So my partners, Sanjeev Bhatia and David Sandberg, went regularly to Haiti in the late 2000s. And we realized that idea of doing an endoscopic third ventriculostomy and cauterizing the choroid plexus, something that Ben Worf had championed in Uganda, might be an effective way of treating all those babies with post-hemorrhagic hydrocephalus that we saw from the nursery in our big public hospital, Jackson Memorial, as well as here at Nicholas Children's Hospital. And we started to use that technique as a way to avoid shunt placement and published those results with a nearly 40% success rate in 2014. And that may sound like not great success, but when you can spare 4 out of 10 children the life of having a shunt, and you can show that the risk of the procedure is limited, then that becomes a reasonable trade-off when the fallback is to place a shunt. And you know, I can honestly say that I think this publication, as well as the work of many others, was a big part in driving the HCRN, Hydrocephalus Research Network, to look at ETV-CPC as a treatment option for treating children with hydrocephalus in North America. You know, we benefited in many other ways from this work, and I'm proud to say that this publication, which was actually my son's public health, master's in public health thesis, where he went to Haiti and spent weeks poring through the records that were all dusty files at the hospital to get follow-up on the children, gave us our first glimpse of what the epidemiology is of hydrocephalus in the developing world outside of Africa. So a great deal has been written about the epidemiology of hydrocephalus in Africa, again, mostly by Ben Worf's group, but nothing really outside of that. So this work, which looked at an environment that's much like Africa, but happens to be 560 miles from Miami, where there's poor infrastructure, there's profound poverty, there's high infant mortality, and there's limited access to healthcare. It gave us an opportunity to study that in a systematic way. And of the many criticisms of this is a retrospective review of what is a surgical case log, but it did let us develop a descriptive series of hydrocephalus as it's seen in the developing world outside of Africa. And we were able to glean both demographic and clinical data from these patients, and that was published just a couple of years ago. So that data set showed us that what you see is that although we see post-hemorrhagic hydrocephalus in infancy in the babies in the nursery, and we see post-infectious hydrocephalus at a few months of age, those children who are being referred to us, 40% of whom had post-infectious hydrocephalus, were remarkably older when they finally came to neurosurgical care. And I guess that's not really a surprise, right? By the time they actually make it to us, those children are about 1.5 years of age. And those that were quite ill in the perinatal period showed about 1 year of age, and that their head circumferences were dramatically large. And that was manifest as children with head circumferences that were in the 60 to 70 centimeter range. And that almost all of those children could be treated with ETV CPC if you could make sense of the anatomy. When we look back at all of that data, there were a couple of interesting observations from it. And from a lot of work, what we saw is that the distribution of the birth of those children was not uniform across the country or across the calendar. And this was an observation that Ben had also made in his work in Uganda, along with Steve Schiff, as they looked at how rainfall drove hydrocephalus in the Ugandan plateau. So we thought, well, gosh, maybe there's something to that here in Haiti. So we used the same model to look at it, and we added the geographic distribution, looking to see if there was some sense of that. And what we saw is that indeed, there were more of these children born during the rainy season, but they weren't distributed evenly across the country. And, Haiti is shaped a bit like a C. It's very mountainous. There's a mountain ridge that runs the entire circumference of the sea. Most of the people live either in the plateau between the mountain range and the Dominican Republic, or here in the valley between the ocean and those mountains. And that when you plotted where those patients came from, with the darker colors being the greater numbers, it did not match the population distribution directly. So that seemed to suggest that there was something about the geography of where these people were coming from that might be of interest. And indeed, when you did all these fancy statistical things that fortunately my kid with the MPH and my trainees understand, you could show that there was a statistically significant variation based on the season, rainfall particularly, as well as the geography. And it seemed to be that those people near the coast were the most likely to develop post-infectious hydrocephalus at the rainy season. Well, it makes perfect sense, because if you have a rim of mountains like you see here that surround Port-au-Prince, which is here in the valley, this is all Port-au-Prince, and not surprisingly, the affluent people live in the mountain, up in the hills, and everybody else lives here in the valley. And all of these things are open sewers that drain sewage and debris. And if you've never been in the developing world when it rains really bad, particularly in the Caribbean, you don't really understand this until you come to Haiti in the rainy season and you get caught in one of these downpours. And there's just a river of debris that runs down from the mountains and into the valley. And this is one of these big channels that carries that debris. There are people bathing and washing clothing in those rivers between the rainstorms. So again, not surprisingly, that seems to drive post-infectious hydrocephalus. Over the years, we would like to think that we're doing better, right? So this series collected patients from 2008 to 2015. And one of the positive things we can see is that the age at the time of referral has steadily gone down over the years that we've been going to Haiti regularly. And I would hope that reflects an opportunity not only for the community to get care, so access, but also something beyond what was the traditional medicine provider of Haiti's approach, which is to say that there's nothing you can do for this. These children should be abandoned because they all die. And thankfully, those children are often left on our doorstep, but at least they're left on our doorstep as infants to manage their hydrocephalus. And I think that's a good thing, because the earlier we can treat these children, the better opportunity they may have for avoiding the secondary injury associated with their hydrocephalus. I would hope that the severity of the hydrocephalus was going down, but that's not reflected in looking at the mean head circumferences at the time of referral. But there has been a slight drop in the age, which is, for that, I'm thankful. And I think we from this epidemiological work, I think you can conclude that yes, post-infectious hydrocephalus is a big problem in Haiti, just like it is in Uganda, though the incidence is slightly less. And I think that's a fascinating issue to address. And that it looks like this has to do with rainfall as well as geography. And I think I talked about the significance already. I don't want to run over my time. How much time do I have, Caitlin? So 8:30?
Yeah, until 8:30, yeah.
Yeah, so let me try to get through the rest of this here in a way that's meaningful. So we're still trying to make sense of this data, and anybody who wants to help us study the CSF samples from these children to look at the bacteriology, we'd welcome the partnership. Steve Schiff has offered to help with that work, but unfortunately Steve struggles with funding just like the rest of us. So someday we're going to look specifically at the organisms involved in this. I think it's going to be different than what they see in Uganda. And excuse me, and will be unique to the semi-tropical environments like we see in the Caribbean. One of the things that I think that we're also very gratifying to see is that the criticism of that prior paper has been that there was no clinical follow-up. And that's justified because we were not able to follow those children reliably. So once we had a trainee in place, UD was able to then do a series of consecutive patients. And granted that although we estimate that there's about 600 new cases of hydrocephalus each year in Haiti, I think that's a significant underestimate, because in the span of a year, UD was able to collect 82 consecutive patients in whom the plan at the outset was to do an ETV CPC. So these are prospectively collected patients where our intention was to do an ETV CPC. They all had 6 months of follow-up. Those 3 patients were lost to follow-up. And we were able to then look at whether that the endpoint was avoiding a shunt at the 6-month follow-up, and then to look at that statistically. And as I mentioned, the age of referral has gone down steadily, right? So at the end of 2015, those children were all about a year. In this series, the children were 7.5 months of age. So the word is getting out that there's somebody to treat hydrocephalus in Haiti. Come to Bernard Mevs, they'll take care of you. We had a slightly lower number of patients with post-infectious hydrocephalus in this group and a slightly higher number of patients with aqueductal stenosis. And I think that's manifest in the outcomes, which I'll share with you in just a moment. Of the 82 patients in whom our intention was to do an ETV CPC, an ETV was only possible in 71. And you may say, what does that mean? You couldn't find the third ventricle? Yes, sometimes you can't find the third ventricle, much less identify the floor of the third ventricle. Sometimes there's no foramen of Monroe. Sometimes there's no recognizable anatomy at all. And what you end up doing at that point is doing a CPC or backing out. And we were able to quantify those that had an ETV, those that had a CPC, and whether it was done unilaterally or bilaterally, and then if there was a complication associated with that. And of course, the presence of pre-pontine scarring was noted because, as Ben has pointed out, that's an important observation. And at 6 months, nearly 70% of the children had avoided a shunt, and that's with pretty good follow-up. 79 out of the 82 children were seen at 6 months for follow-up. And at the last follow-up, which was slightly under a year, it was still at about 50%, which is, I thought, very respectable considering the population we serve. And of course, the ETV success score was important in predicting who would succeed. And that obviously, if you weren't able to do a CPC at all, or there was only a tiny bit of choroid plexus visible in one ventricle, your outcome was pretty poor compared to whether you were able to do bilateral CPC effectively. That's clearly was associated with success. We talked about this. The presence of post-infectious hydrocephalus was associated with failure. If you had a high ETV success score, that was associated with success of the ETV. And what really made a difference here was having UD, right? UD was there to take care of every single one of these patients the same way. He'd become very capable. At that point, he'd done over 100 ETV CPCs before we started this project. So he had been quite capable at that point, and it's proved in his success rate here. So obviously the goal here is to continue to work on follow-up and to look at the long-term development of these children to see if we really are succeeding in the ultimate outcome, which is to protecting their development from their hydrocephalus. Where are we today? Well, I'd like to tell you that we're better off, right? This was from a few years ago, 2019, where the State Department said, don't go to Haiti because of the violence and the unpredictable social situation there. That was 2019. It's no different today. This was just over the weekend. Of course, when you think about what's going on in Russia and Ukraine, it pales by comparison. but travel to Haiti still is not advisable at this point because of the chaos. I think the misery in Haiti continues in many ways. The assassination of their president, the earthquakes from last summer, the hurricanes from last hurricane season, and then the kidnapping of the medical missionaries that resulted in the inability for our teams to go. We've not been able to send a team, either a medical or surgical team, to Haiti since the fall of 2019. The hospital, though, has become the neurosurgical referral center for the country. If you have a traumatic injury and you're a politician or a police officer or a military person, you get sent to the Bernard Mebs MediShare neurosurgery unit. They have continued to treat hydrocephalus and with a limited ability to take care of the poor because of funding. And of course, the children with spina bifida and the congenital malformations end up going last unless they have hydrocephalus that can be treated. Their spinal defects granulate in, the encephaloceles remain untreated. The problem, of course, is limited OR capacity. We still don't have any functioning sophisticated neurosurgical equipment in spite of trying several times to send a microscope. By the time it gets there, it's not serviceable and there's no one to fix it because we can't send a technician into the country. And then the unreliability of the infrastructure is a real problem, right? So I mentioned that generator that's what's left of the CT scanner that you see there in the lower right. It's a 2012 unit that was brought there in a trailer. It was very contemporary when it was there. I have a picture of the technician. He lays on it and tries to manipulate the buttons from the gantry. The power goes out regularly. By the time the generator kicks in, it scrambles the software. So you get it, right? Security and safety become an issue. We have no consistent funding. But I think the real problem now is that we've lost the consistent mentorship for UD. And, we used to see Ariel Henry regularly whenever we would go. He would come visit the clinic. He would work with UD in our absence. He would handle the difficult cases with UD. He's a very capable cranial and spine surgeon with the tools he had available to him. But obviously, since the assassination of Moise, Ariel Henry has become their president, prime minister. I think the poor man has aged a decade in the last 8 months. And that's also left the program without mentorship. So we continue to learn from our experiences. For those who would consider doing something like this, I think it's obvious, right? You need to understand the local culture and what resources they have. You need to identify a partner that you can work with. And you need to take the time to slow down and listen to them so you understand what they need. And Ariel Henry was very instrumental in helping us understand those things so that we started the teaching program in a way that made sense. Be careful how you handle supplies and equipment, right? That's a big deal. And you have to persevere because there's lots and lots of children. You'll try to do too much and then you'll get frustrated. I love to show this, right? This quote is a paraphrase from what the pediatric section told me years ago. I won't name any names, and I won't tell you the year, but it's gratifying to see how the pediatric section has now fully embraced global health as something important for what we do. And again, I thank you for the opportunity to talk to your group about global health and our efforts in Haiti. It's really been my privilege. I want to thank all the people who have helped over the years. We couldn't do it without you. There's a list of some of them, but of course you can never keep track of them all. And of course, probably the most important has been my partner, Sanjeev Bhatia, who passed away just a few years ago. Without him, none of this would have been possible. So thank you again. I put my mistakes out there for anybody who would like to learn from them. Feel free to let me know. That's my email at the bottom. So thank you, Caitlin and Rupa, Mark, for the opportunity. I'm sorry I ran over.
No, thank you so much, John. It's amazing to see and hear the differences, of course, that we all experience based on differences in geography and political climate, and there's just so much for each one of us to learn from every different region that we attempt these efforts in. I learn every time I hear more of your experiences there, and you pointed out some really interesting directions for us to go, even as we start to tackle the pediatric realm, in Tanzania, which we are just starting to do over the last couple of years. So we can't thank you enough. I know everyone does have to run to the OR if there are any burning questions. John provided his email. He's very approachable and very accessible.